ECG, so it might be difficult to say whether these changes are from his previous ECGs if he didn't have a baseline to look at, or whether these are new changes from the toxin. Patients can often present with co-ingestions. So now you have multiple effects on the heart from the different drugs the patient was exposed to. And then also everything that we discuss in here is not based on randomized controlled trials. Like most of the toxicology is based on reports and case series. So there is no solid evidence behind what we know. So why should you stay and listen to this talk? Well, we'll try to break down and identify what are the ECG patterns associated with some of the common cardiac toxic exposures. We will try to understand some of the pathophysiology mechanisms, why these ECG changes happen. We will try to identify what are the life-threatening ECG findings. The patient might look well, but then you have this ECG finding that might trigger you to start your treatment before the patient deteriorates. And then we'll try to apply the ECG interpretations to guide our diagnosis and management. Now, the drugs can have both direct and indirect effect on the heart. So let's talk first about the indirect. So toxins at large doses can give you electrolyte disturbances. So you might have changes of hyperkalemia or hypokalemia on the ECG. The heart might have dysfunction because of severe acidosis or because of severe shock. These all can also precipitate cardiac ischemia. So you might have changes of acute ischemia because of the profound shock or profound effect of the drug on the heart. Also, patients might have severe hypoxia. So, for example, as in, let's say, cyanide poisoning. So you can, again, develop ischemia because of severe hypoxia. And then you have drugs which can directly stimulate the vagal nerve. So you can have bradycardias, not because of direct toxin on the cardiac membranes, but because of vagal nerve stimulation. But the drugs that directly affect heart, we can divide them into three groups. So we can say those that are block sodium channels on the heart, those that block potassium channels, and then those that block calcium channels. And we'll discuss these a bit later. Now, all of you here know how to read ECGs, and I want you to sort of just take a step back and try to look at the ECG with the tox glasses on. So how do you look at it differently? So first of all, when it comes to rate, just by identifying whether patient is having bradycardia or tachycardia can help you put a differential diagnosis of what the patient might have taken. So there are known drugs that give you bradycardias, and then there are those that can cause you tachycardias. However, even those that commonly cause bradycardias at very high doses can give you arrhythmias and tachyarrhythmias. Rhythm. So you want to identify any tachyarrhythmias, as we said, and you want to look for any AV blocks. When it comes to axis, we don't really care at the moment whether a patient has a left or right axis, but rather, does the patient have a terminal R in AVR? Okay, so a terminal R in AVR more than 3 millimeters is a significant abnormality with specific drugs such as TCA, and we are going to discuss these more, so don't worry. Then when you look at the QRS, you want to look for abnormal morphologies of the QRS. Does the QRS look narrow or wide? Now, by definition, a wide QRS is more than 120 milliseconds. Okay. But when it comes to toxicology, we know that more than 100 size of QRS, more than 100 milliseconds, is associated with arrhythmias. And this is the number which you want to start treating a wide QRS. It's 100, and you don't wait when it's 120. Next, you want to look at the QT size. Do you see a QT prolongation? And we know that a prolonged QT can precipitate arrhythmias, which is torsade de poids. And we're going to discuss further what are the different methods of how we can accurately calculate the QT. You want to look at the PR size. Do you have a prolonged PR, which again tells you that patient is having a degree of first degree of AV block. And then you look for ST and T wave changes, and you're basically looking for any abnormal morphologies of the ST and segment, or you're looking for signs of ischemia and ischemic changes. So from now on, we're going to dive into cases, and I always believe that the best way to learn is through storytelling and through um, having a virtual or sometimes real patients to discuss from which we can learn. Okay, so let's start with our first patient. So this is a lovely 75-year-old lady. She has a past medical history of hypertension and ischemic heart disease, and she has early dementia. So this lady woke up on on Thursday. I'm sorry, she woke up on Wednesday and she thought it's a Thursday. So she saw that her Wednesday medication was still full. So she thought she forgot her Wednesday medication. So she took them plus the Thursday medications as well for her hypertension. She started to feel drowsy after that. She took a nap. She got up and then she thought it's already the next day and took yet another third dose of the medication, which is supposed to take OD. So she presented to emergency department, awake, slightly drowsy, bradycardic at 37 and slightly hypotensive. And this was her first ECG. So I'll give you a moment just to take a look and try to identify as many abnormalities as you can see. And I know this is it's difficult with the online having an interactive session, so I'm happy to answer questions at the back, but I want you still to take a moment to try to identify the abnormalities.
Laila, we can pause, and allow them to, share their thought through the chat.
Sure.
So we have here someone saying this is sinus bradycardia.
Okay. All right, so let's talk about that first. So somebody said it's a sinus bradycardia. Now, this is obviously bradycardic, but is it really sinus? So as you can see, there's no P waves over here. There's a P wave over here, but we don't have a consistent P wave before every QRS. So this is not a sinus, like a bradycardia. However, if you have a narrow QRS with regular rhythm and no definitive P wave, so this is a junctional rhythm. Right. In here, you can also see that the patient has changes in the inferior leads. So you have slight ST elevation over here in AVL. You have slight ST depression T wave inversions in inferior leads. So this patient actually has bradycardia that has precipitated an acute ischemia. She also has some changes, T wave inversions um, from her previous septal MI, and she had a previous LVH with hypertension. So this is an ECG not to discourage you, but just to show you how complicated it gets when you try to identify really what's acute and what's not, but not to miss on top of bradycardia that you have underlying ischemia. So this is a patient who took an overdose of bisoprolol. Now, we're not going to dive into management of agents today because our time will not allow us, and we want to cover as many ECGs as we can. So this patient was treated with glucagon for beta blocker toxicity, after which the sinus rhythm returned and the heart rate increased to 70. And the T wave inversions also resolved. So her treatment of the severe bradycardia also improved her ischemia. Now, when you think of what are the toxic bradycardias, there's a really large group of drugs that can give you bradycardia, and these include beta blockers, calcium channel blockers, clonidine, or glycosides, benzodiazepine overdose, cyanide also at large doses, cholinergic drugs, and opiates. So this is another example. Okay, similar presentation. You can also see that in this ECG, we have no clear P waves before every QRS, and the rhythm looks regular, bradycardic. So this is, again, a junctional rhythm. So this is a 57-year-old patient who came in with lightheadedness after she was started on new blood pressure medication. So this is a patient who was previously on beta blocker, but she had now an additional amlodipine added. So as you can see, these changes can also be seen with calcium channel blockers. So you can't really tell by just looking at the ECG of, whether this was a beta blocker or a calcium channel blocker. This is another example. Now over here, you can see that there is you have regular QRS complexes and regular P waves, but there's no relationship between the two. So this is a patient with a third-degree heart block with an with narrow QRS complex. And this is an example from a patient who took metoprolol. So what have we learned so far? So beta blockers and calcium channel blockers can all cause bradycardias, and they can all have different degrees of AV blocks. And you can't really correlate of type of AV block that you have with a degree of intoxication. Okay, so let's move on. So this is an 85-year-old gentleman. This is a patient with a past. He was brought to the emergency by his son because he had an episode of syncope. So he has a past history of diabetes and atrial fibrillation, for which he was taking Satolol. And recently, he has been having frequent atrial fibrillation relapses, so he couldn't get an appointment with his cardiologist and visited his family physician. He increased his Satolol from 80 milligrams BID to 160, so he doubled the dose of his Satolol. Now, a few days later, patient was complaining of ear pain. He visited an ENT and he was prescribed erythromycin for otitis media. This was his presenting ECG. So I'll also give you a moment just to try to read the ECG. And just if anybody can write, what's the first thing that hits you? What is weird about this ECG other than that it's bradycardic? Okay, any results? Afra, if you can help me just read out the result because I will not be able to open the chat at the same
Yes,
time.
sure. So there is like someone who's saying ST depression, I think. 1 second. Okay, so we have actually multiple, mashallah, they're interacting, you know. So there is actually, okay, so ST depression, prolonged QT, prolonged QT interval, no P wave, long QT, good. So many of them noticed that.
Okay,
One
perfect.
QRS complex, and then inverted T. Most of them
Okay,
actually,
very good. Yeah, very good. So I'm very happy that a lot of you were able to see that there is a very long QT interval. So first of all, you see that these are the regular QRS complexes. And then you have also um, in between, you have, sorry, just my laptop froze, I think. In between, you also have additional PVCs. Now, as you can see that the QRS complex, the QT is very prolonged. Okay, from the normal QRS to the next, which is the PVC, you have a prolonged QRS complex. So this is, you have absent P waves, junctional rhythm with premature complexes, and you have very severe QT prolongation. Now, let's take a moment and understand how the QT prolongation is calculated. So what's the correct way to measure? If you have a normal QRS, a T wave without a U wave, you would use the intersection of the T wave with the isoelectric line over here. And that intersection is where the QT interval ends. So it begins with the first upstroke or downstroke of the QRS complex with the end of the T wave where it intersects with the isoelectric line. So this is the correct way to measure the QT. Now, if a patient has a U wave, if it's a small U wave that's not fused with a T wave, you would draw a line from the T wave down, and then where that line intersects with with the slope of the T wave. That's where you would end your QT. However, if you have a very large U wave which is merged with T wave, then your QT interval would be calculated after the U wave. Now, there are many formulas out there that are used to um, calculate QT. Now, we've learned this in med school. The most commonly famous one is the Bazit formula, which is QTC equals QT over square root of RR. Now, just to know that if you've been using this formula right, you need to know that the QT interval is measured in milliseconds, but the RR interval is in seconds, okay, which makes it a bit confusing when you want to plot it down. Now, the Bazit formula has good sensitivities. It was actually found to be 98% sensitive, but the specificity is only 67%. Now, what does that mean? When we talk about sensitivity and specificity, we're talking about how good is this formula to predict that the patient might have arrhythmias. So, what is a pathological QT prolongation? The QT nomogram was found to actually have perform better than any other calculated formula. So it's found to be 97% sensitive and 99% specific to predict a torsad. So what you do, you use it similarly. If you're familiar, have to use the acetaminophen poisoning nomogram. So this is the same. So you will measure the QT from the way we discussed, and you will plot it onto this graph. And depending on the patient's heart rate, you know if the patient is above this line or not. So anything above this line means that the patient has abnormal QT. And it's very easy to use. So as you can see, if somebody has a QT of 350, just by eyeballing it, you might think that this is normal. But if his heart rate is 140, so that is pathological QT. Now, going back to our patient, while you were trying to decide which formula to use to calculate his QT, the patient changed his rhythm and he started gasping and he lost his pulses. So patient developed typical pattern of torsad. So he received 200 joules of defibrillation and was given 2 grams of magnesium stat. This was then followed by lipid emulsion, and the patient achieved ROSC. After that, the patient received a full beta blocker therapy and went for dialysis. Now, what happened here? So first of all, this patient had an increased dose of sotalol, but other than that, he was also prescribed erythromycin, and the combination of erythromycin with sotalol increased his QT. Now, there are a lot of drugs that can prolong your QT, and I've deliberately put them so small so you don't try to read them, but so that you know how many there are. There are a lot of drugs, and you need to be aware that these drugs exist. And you need to be aware when you prescribe new medications to a patient that you double check if those don't interact. We do have at Cleveland very good alarm system from the pharmacy, but a lot of these drugs are not on the list. So if you don't check them yourself, you're going to miss that you're increasing patients' risk of QT prolongation. A great, easy, free tool that's available to you. And there are many other tools, but I like using this one. If you download Medscape, it has a drug interaction checker, and you can basically put these medications in. So as you can see, sotalol with erythromycin, they are contraindicated because they can prolong QT. And this is a very easy way to always double check drugs, even simple things like flu medications and azithromycin. And if a patient already is like on antipsychotic medications, you're already increasing his chances. Okay, let's move on to the next case. So this is a sad case. This is a 32-year-old ICU nurse. She was struggling coping with stress during work with COVID. She was brought to ED after 45 minutes from the time she swallowed 70 tablets of propranolol. So she took 70 tablets of 40 milligrams of propranolol. So that's a total of 2.8 grams with a suicidal intent. So she presented initially with pretty much looking stable vital signs, but her GCS was overall 13. Now, this was her initial ECG. Okay, so I'll again give a chance for people to just quickly mention on the group. Very good. So somebody mentioned white QRS. Yes, thank you very much. Anything else? Terminal R wave. Very good. Sidecars. I'm not sure what sidecars are. Okay, there's also QT prolongation. Very good. So this patient actually has both. So if you look at her QRS is prolonged, but her QT is so QT and QRS both are prolonged. And as you can see over here, she has a high R in terminal R in AVR. So this patient, if you look into more details through this ECG, she's having first degree block because she has a prolonged PR segment. She has a prolonged QT, prolonged QRs, and a terminal R in AVR. So this patient was started on sodium bicarb. She was intubated, gastric lavage. She received fluids. She started to become bradycardic, hypotensive. So she was given atropine, started on calcium chloride, epi infusion, high dose insulin, euglycemic therapy. She continued to deteriorate. She started to become tachycardic then and more hypotensive. And this was her follow-up ECG. So as you can see here, that now she started to have very wide QRS. Okay, this is extremely wide QRS. And whenever you see this wide QRS, you always need to think of that this could be a TCA poisoning or sodium channel blocker poisoning or hyperkalemia. So very, very wide QRS. Always think of hyperkalemia or sodium channel blockers. So following this, she received yet another repeated dose of sodium bicarb. When she started to become alkalotic, she was started on hypertonic saline. She still had resistant VTAC. She was given lidocaine and phenytoin. Intralipids were started. But unfortunately, this patient proceeded then to go into asystole and unfortunately passed away. So sodium channel blocking agents, again, there are a lot of drugs that can give you this picture. So we tend to know most about them from TCA literature, but you can see them with cocaine, you can see them with some beta blockers and some calcium channel blockers even. So again, always double check the list of drugs that the patient is on, and whenever you're prescribing something, you make sure that you are checking if these can interact and cause prolonged QRS. Okay, so let's recap quickly. So beta blockers and calcium channel blockers, we learned that all can cause bradycardias and AV blocks. Beta blockers, you have, those that can block potassium channels, so those that can prolong your QRS by blocking potassium channels. From the beta blocker group, you have sotalol, propranolol, and acebutolol. And from calcium channel blockers, you have nicardipine. So these are the ones that can prolong your QT interval. Now, those that can block your sodium channels and cause prolonged QRS from the beta blocker group is propranolol. As you can see, this patient had propranolol poisoning, and she took both. And you can also have from calcium channel blockers, verapamil and diltiazem can give you prolonged QRS. So on top of your normal treatment that you've learned how to treat beta blocker poisoning or calcium channel poisoning with high dose insulin therapy, you need to know that if these findings are there, you need to give something extra. So if you have prolonged QT, you need to give magnesium, and if you have wide QRS, you need to give patients sodium. Now, I'm going to very quickly just talk about mechanism of these two. I'm not going to bore you too much with pathophysiology because I think it's nothing that sticks in our mind. But for you to just to understand, and since I believe we have a lot of tox interested people in the group. So beta blockers, they basically block your cyclic AMP, okay, which means that they block catecholamines. And then you have your beta 1 receptors and beta 2 receptors. Now, we know that some drugs act only on beta 1 and some on beta 2, but at very high doses, actually, these can interact. So, where are your beta 1 receptors? These are your receptors in the heart. So, beta blockers have negative inotropy, so they cause myocardial depression. They have negative chronotropy, so you have bradycardia, and dromotropy, so you have AV node blockade. And then your beta 2 receptors are found in your GI tract, in your lungs, um, in your kidneys, and in vessels and blood vessels. So beta blockers are lipophilic, okay? Um, Especially propranolol is the most lipophilic, and that's why it causes CNS suppression quickly. And unlike calcium channel blockers, so beta blockers present more with drowsiness than calcium channel blockers. They are rapidly absorbed, so symptoms can start anywhere between 1 to 3 hours. They also block glucose absorption, so the patient present with hypoglycemia. And as we talked, you can have effect on the heart with blocking sodium and calcium channels, and can cause prolonged QT with propranolol and sotalol. For calcium channel blockers, you have the two groups, which is dihydropyridines and non-dihydropyridines. So if you look at their effect, so dihydropyridines act more on the peripheral vessel, so you expect more hypotension with these drugs, whereas non-dihydropyridines act more on the heart, such as verapamil and diltiazem. So they have, again, similarly to beta blockers, negative inotropy, negative chronotropy, and negative dromotropy. Calcium channel blockers are also rapidly absorbed. They actually they block insulin, so they can give you hyperglycemia. Okay. But don't rely only on this to decide whether this is calcium or beta blocker. And as we talked about, that they can cause a blockage of your sodium channels and prolong QT. Now, I need to rescue the group because I know a lot of you fell asleep. So let's go back to our cases. So next, we have a 17-year-old girl. She had a fight with her parents. So she took 20 tablets of her medication she uses for depression 30 minutes ago. She came with an attitude. She was chilled. She didn't want to talk to us. She was on her phone and looked great, but she was slightly tachycardic on the ECG. Now, this is her initial ECG. So let me again ask the group, what do you see? Okay, perfect. So again, we have prolonged QRS. And we have wide QRS, terminal R in AVR. Very good. Okay, perfect. No P waves. Very good. Okay, so what do you think about this? What do you call this pattern? Any ideas? So what does it look like? If this patient was not tachycardic, but you see this, yes, excellent, Brugada. So this looks like a Brugada pattern. Very good. All right, and this is your terminal R in AVR. So patient, I've written here sinus tachy, but I agree that there are no P waves over here, so it's probably not a sinus tachy. So there is a prominent R in AVR. There's right axis deviation. There is Brugada pattern, and there is wide QRS. Okay, now QRS duration. Does it really matter? So QRS duration was actually found to have a prognostic value. So they looked at retrospectively patients who had TCA poisoning, and they looked at their ECGs, and they found that patients who had QRS less than 100 milliseconds were not found to have seizures or arrhythmias. But those that had QRS more than 100 milliseconds, 34% of them had seizures. So it was predictive of having seizure as well. And 40% had ventricular arrhythmias. Okay. So QRS duration was actually found to be more reliable than TCA levels because they are known to be very unreliable to predict prognosis. The terminal R in AVR was also found to have a prognostic value. So if you have an R which is more than 3 milliseconds, so this was associated with severe toxicity. It was a strong predictor for arrhythmias and seizure and correlates with the need for intubation and ICU admission. So if you have a tall R in AVR, that can tell you that this patient will have can have a bad outcome and needs to have an urgent management initiated. Okay, so you have to take this patient seriously. This is another example. So this is a patient who had diphenhydramine overdose. As you can see over here, you have slightly wide QRS. You have an picture of an incomplete RBB pattern. Okay, so you have an RBB, and you have also over here, you don't really have a terminal R in AVR. Okay, but just see when this patient was treated with sodium bicarb, benzos, and was given magnesium. This was the follow-up ECG. So at the bottom, you can see how much the ECG improved. He still had a bit of a QRS presentation, a little of a bundle batch block in the, sorry, just losing my laser. So still had a bit of RBBB, but the heart rate already slowed down and the QRS narrowed. So important drugs to remember that are contraindicated when you have a TCA toxicity, but a lot of these apply to also all sodium channel blockers. So remember, class 1A and 1C antiarrhythmic agents are contraindicated, and these are your procainamide, quinidine, flecainide, and propafenone, okay, because these can also increase your QRS. And then you have your class 3 antiarrhythmic agents, which is amiodarone. On top of these, you have phenytoin, and you have physostigmine, flumazenil, beta blockers, and drugs that prolong your QT because TCA can cause both QT and QRS prolongation. So why phenytoin? Because it was found that you can precipitate seizures if you give phenytoin to patients with TCA toxicity. And with physostigmine, so physostigmine, it might reverse the anticholinergic delirium. But again, it was found that with TCA toxicity, it carries a high risk of asystole and also seizures. Regarding flumazenil, so in flumazenil with TCA, um, the reason why it's not really advised is because there is a fear of concomitant benzodiazepine ingestion and again, a risk of precipitating seizures. And even though these patients are tachycardic, you do not want to give them beta blockers because you don't want to precipitate hypotension. Okay, let's move on to our next and last case. So this is a 47-year-old lady. She's known to have ischemic heart disease, CHF, diabetes, hypertension, and AF. So your typical everyday geriatric patients. She was brought by her husband after she was found obtunded at home. She was complaining for the past 1 week of worsening fatigue, on and off with diarrhea. And this is the list of medications that she's on. Okay. And initial VBG showed this. So you can see that the patient is quite acidotic with a pH of 7.1 and her potassium is 6.2. She's also having hyperglycemia. So she's with a bicarb of 16. So she has a picture of DKA. She has increased creatininuria. So she has really mixed picture of a lot is going on. She has acidotic, DKA, there is AKI, she's hyperkalemic. So you would normally want to treat her as any other medical DKA patient. But you have to remember of what these circumstances can cause and what effect they would have on the regular drugs that she takes. So this is her initial ECG. Okay, this is rather a common Arab board exam question. So if anybody can answer, what do you think this is? What do we call this ECG? Yes, very good. Bidirectional VTAC. Excellent. So this is a bidirectional VTAC. As you can see, one QRS is upward and the other one is downward. Okay, and this is something that we see at times with high digoxin toxicity. Okay, it's not unique. You can see it in other circumstances, but it is commonly associated with um, it's a common, not a common presentation of digoxin toxicity, but rather um, it was often the most often it's reported is with digoxin toxicity. This is another example where the ECG looks very bizarre, but at some point you can tell that you have complexes which are positive and complexes which are negative. Okay, so if you see a very bizarre ECG, think of digoxin toxicity or potassium abnormalities. So what does digoxin do? So digoxin can inhibit both sodium and potassium ATPase on the heart. So that causes increased intracellular calcium and that causes positive inotropy. So you have increase in myocardial contractility. And that's why we use digoxin in patients with heart failure. And it has a negative chronotropy and increases the vagal tone. So your typical patients are heart failure patients with atrial fibrillation that are put on this treatment because you want something to slow down their atrial fibrillation, but still have a positive inotropy on the heart so that the heart can still improve in its contractility. Now, digoxin is famous for a lot of its interactions. It interacts with antibiotics, with tetracyclines and erythromycin. It interacts with antiarrhythmic drugs such as amiodarone. It can interact with calcium channel blockers, a lot of antacids, over-the-counter antacids, which we often don't think about that they can have an effect on digoxin, and also on very common medication that patients are on is furosemide. We also know that digoxin has a close effect with potassium. So high potassium increases digoxin toxicity, and toxicity, sorry, low potassium precipitates digoxin toxicity, and digoxin toxicity can cause an increase in potassium. Okay. So when somebody's hyperkalemic, that's actually good for their digoxin. So it actually reduces digoxin efficacy because um, it tries to like there's a mechanism where it tries so you have less calcium influx into the myocardium. So digoxin toxicity has a wide range of effect on the heart. So at low doses, it gives you more bradyarrhythmias. So you would see more of sinus bradycardia, AV blocks, and sinus poses. And then at high doses, it gives you more tachyarrhythmias. So you would see things like atrial injunctional premature beats, atrial tachycardias, atrial flutters, atrial fibrillations, accelerated junctional rhythms, multifocal VTAC, bidirectional VTAC. So a lot of abnormalities at its higher doses. So this is your typical digoxin effect on the heart, which are the normal findings with digoxin medication. So patients who are on digoxin, normally you would see an irregular rhythm because they normally have an atrial fibrillation that you're trying to slow down, but usually should be more on the bradycardic side. So you will see that they can have AV blocks, which are considered still normal. You can have the scoop or sagging ST segment, which we call um, the hockey stick or reversed hockey stick. You can have a normal short QT and you can have prolonged PR. So that's your first degree AV block. Okay, so these are your normal findings of digoxin. Okay, another name for the exam sake is the Salvador Dali mustache. Okay, that's the shape of the ST segment with digoxin. Okay, now this is another example of digoxin toxicity. And as you can see here, although the patient's heart rate is slow, this is too slow. Okay, so if patient is too bradycardic, that means this is already a toxic effect of digoxin. Patient should not be this bradycardic on digoxin. This patient also has a very fast atrial response. So this is what we call PAT, or paroxysmal atrial tachycardia with atrial block. So you have an atrial rate of 214, a ventricular rate of 40. Now, although this, you would think that you would treat this with digifab, but these patients actually need some atropine because they're very slow. So, take-home points. Always suspect toxicity in patients with abnormal ECGs, and if they have polypharmacy, treat ECG abnormalities early with the correct antidotes, and always verify drug interactions before prescribing new medications. And don't forget, um, always call your poison center. I hope you all know the number. And these are my references. And I think we have some time and happy to take any questions from the group. Thank you very much.
Thank you so much, Dr. Laila. That was amazing talk. I mean, I enjoyed it. I'm sure also my resident enjoyed it, and I'm sure that the attendees enjoyed this talk. So we're gonna keep like 5 minutes or 10 minutes for any question. If anyone has a question, please share out your question through the chat. So as I can see, there's a lot of thank you, but there's no question.
Thank you. So many hands and hearts. Thank you very
Yes,
much.
exactly. I honestly really enjoyed it. Thank you, Dr. Laila. Thank you for this great talk.
Thank you very much. If you really have any particular question, or if I went too fast over any section, please feel free to ask. So it means either they understood everything or nothing.
So here there's a question. The QRS interval, any significant value?
Okay, so for the prolonged QRS, let me go back to this slide. When we talked about sodium channel blockers, when we have a prolonged QRS, so we talked about in TCA toxicity, right? That you can have, let me just open the slide for you. So if you, in sodium channel blockers and TCA toxicity, if you have a prolonged QRS, okay, so if it's less than 100, it was not found to have any it was not found to have any arrhythmias or seizure correlation, but once it gets more than 100 milliseconds, so that's when you should be worried. So you should have less threshold than your regular ECG, because in regular ECG we think that up to 120 is still normal.
Yes, and just to add on Dr. Laila, so just keep in mind that you really like in an overdose in toxicity, you need to really look at the QRS. It's very important. And as Dr. Laila, she already mentioned in her presentation, there are like a large group of medication, even like daily medication that we used as simple as like, for example, diphenhydramine. They have sodium channel blocker effect. So basically what happened is that prolonging QRS, it increased the risk of both of seizure and arrhythmia. That's why we need really to treat these the QRS prolongation. So usually, like if you have, I mean, a QRS more than 140, the risk of seizure is really high, it's almost 30%. If you have a QRS more than 160, it become actually 50% of your patient definitely will go to some kind of ventricular arrhythmia. So that's why they are important. Do we have any other question in the chat? Excellent. Seems that there is no more questions. I think, I mean, we can end our talk for today. So I would like also again to thank Dr. Laila for this great presentation, and thank you all for who attended us. Attended the webinar. Please keep in mind that this webinar also is recorded and it will be soon uploaded at ESM website under the toxicology committee group. And please keep in mind that after you, finish the webinar or log out, you will receive a survey to evaluate the webinar. Please make sure to do it. It wouldn't take time. It's and to the point and very direct. Thank you, everyone.
Thank you. Thank you again, Dr. Afra, for this opportunity. And please carry on the great work. And I hope you inspire other trainees and other physicians to continue similar efforts and in other aspects of emergency medicine. I'm yet to look for my focus rounds, so I need a buddy to help me start the focus round, so we can do similar work to you, Dr. Afra. Thank you
Yes,
very much.
sure. If you want, you can share your email, maybe in the chat. And those who are interested, since we have some time, they can
Yeah,
just email you.
my email is down here, so it's Hussein
Yes,
L at
yes. Please take a
CCAD.
picture. Yes. Excellent.
Right, perfect. Thank you very much, everyone, and hope you have great holiday. And for those who celebrate Christmas, I would be really proud if you attended this lecture on your Christmas day. Um, Thank you very much, and have a happy New Year.
Thank you, my dear Leila. And yes, Happy New Year, because actually next time we'll see you, it will be already the new year.
Yes.